Alright guys, let's get busy talking about placental pathology. When it comes to this video, we're going to cover everything related to the placenta and umbilical cord. So let's go ahead and orient ourselves to our diagram here. Here is our placenta, and we like it in this upper portion of the womb during a normal pregnancy. This is where it should properly be located. We're going to talk about some abnormal locations of the placenta and the umbilical cord, and it's also important to know that this is going to be our cervix down here, and our cervix is going to be the connection between our vagina and our uterine cavity. And then finally we have our amniotic sac here, which is full of amniotic fluid that kind of suspends the baby in kind of this weightless state and allows it to have room to grow, and it's not going to be like jammed up against a wall here too much because it has a nice padding from this amniotic fluid. And then additionally, when it comes to these are all pathologies, and I want you to pay attention to important differential forming and some important points to our differential that I want you to pay attention to throughout, and I will be prompting you towards, are going to be the type of bleeding that we have. So is this bleeding painful or non-painful, and is this bleeding continuous, or is it going to kind of come and go? And then additionally, I want you to focus on fetal distress and also maternal distress, and all of these are going to help you identify the pathology and where blood may be coming from and where the placenta may be. And so I want you to really focus on these three things because it will really help you in this video. So let's go ahead and get started. Let's talk about our placenta previa first, and let's go ahead and go over to our diagram. I'm going to mark up this diagram a lot in yellow regarding placenta previa, and then afterwards I'm going to erase all my annotations before we go into the next pathology. So in placenta previa, here we have the location of a normal placenta. So I'm going to put a little N here because this is where we normally like it. In placenta previa, we have our placenta that is going to be covering the cervical os, or really close to the cervical os, usually like within 2 centimeters of the cervical os. And this is problematic because we like this area near the cervix to be open because the baby has to eventually come through the cervix and out of the vaginal canal. And so when we have placenta previa, we basically have the baby that's pushing against a place where there is nowhere to go because the placenta is blocking it. And you can imagine that as the baby gets bigger and bigger, we're going to have it pushing up against that placenta from time to time, and that placenta is going to be jammed up here against the cervix, and this is going to cause some bleeding from time to time. So we can expect more and more bleeding to occur as we get later and later in pregnancy and the baby is getting bigger. However, this is going to be painless bleeding because this bleeding is coming from the placenta, and the pregnant person has no pain receptors in the placenta, so this bleeding is not going to cause any pain. So like going back to our diagram here, we have bleeding and it's non-painful. And is it going to be continuous? It's going to be off and on. It's going to be depending on how hard the baby is pushing on the placenta and like what position the mother is and how big like those pushes on the placenta are going to be. That's going to determine how much bleeding, but we can usually think of this as episodic bleeding throughout the 3rd trimester. This is usually going to be identified on ultrasound, and so this is something that can be monitored, but this is going to be the pathophysiology here of placenta previa. So let's go ahead and review. It's going to be improper implantation location of our placenta, and we're going to have our placenta extending over our cervical os. Some risk factors here are going to be C-section, increased maternal age, multiple gestations, because if we have multiple gestations, we have multiple placenta, and so there's going to be less real estate for each one, so there's an increased chance that it could go over the cervical os, and then also a previous placenta previa puts you at risk as well. In terms of our presentation, we mentioned that this is found on routine ultrasound, resulting in painless 3rd trimester vaginal bleeding that can be kind of episodic depending on the position of the baby at any given time and how close the placental is to the cervical os. And then we can also have pain or contractions, but I want you to note that this is not going to be pain from bleeding. This pain is just going to be related to the baby pushing down on the cervix and the cervix being sensitive to that, and that's going to be causing the pain and contractions. It is not related to the blood that is coming from the placenta. And then finally, it's important to note that there is no fetal distress here as opposed to vasa previa. So during placenta previa, our fetus is not going to be under distress because the blood supply from the umbilical cord is just fine. There's nothing wrong there. And so we're not going to expect any fetal bradycardia, and we're not going to expect any maternal distress as well. In terms of management, step 1 is not heavy on management, but one thing I want to mention here is they like to ask that there's no digital vaginal examinations, and this is due to hemorrhage risk. So if you're sticking up a finger into the vagina and you're poking around, that's going to cause that placenta to bleed more. And if you really hit a major blood vessel in the placenta, then you're going to get some major bleeding and a hemorrhage there. So that's why it's contraindicated. So I want you guys to take a screenshot here if you need to of this pathology, because I'm going to clear it and move on to our next color. So moving on, let's talk about our vasa previa. And our vasa previa I'm going to be talking about in this dark green color. And essentially in vasa previa, it's all about the umbilical cord. So here we have a normal umbilical cord that you see kind of comes from the placenta and then it goes right into baby's umbilicus. However, in vasa previa, what happens is our umbilical cord is going to travel in front of the cervical os before wrapping back and inserting into the baby's umbilicus. So we're going to have an umbilical cord that kind of looks like this. And it's also going to be associated with something called a velamentous umbilical cord. So let's talk about what that is. So the umbilical vessels are traveling through the umbilical cord. These are going to be the umbilical veins and the umbilical artery. And you'll see that they travel inside the protective coating of Wharton's jelly, which is inside this green structure. However, in the velamentous umbilical cord, we can have our vessels actually exit the protection of Wharton's jelly. So they can travel out here unprotected, like right in front of the cervical os, and then they may like slip back into the Wharton's jelly at some point and continue on into the fetus. And this is really dangerous because Wharton's jelly is protective. And so when this velamentous umbilical cord is having its vessels outside of that protective jelly, it puts them at risk for rupture. So what can happen is we can have like a fairly normal-ish pregnancy until we get rupture of our amniotic sac membrane. And when that membrane ruptures, we're essentially going to have water coming out, this amniotic fluid, and that amniotic fluid was previously suspending the fetus in a weightless position. And now that fetus is really going to be pushing down hard on this unprotected umbilical cord that is running right in front of our cervix, which is the fetus's pathway out of the womb. And so you're going to get this interesting triad here that we're going to highlight for you. And the triad is going to be membrane rupture followed by fetal bradycardia. And this is because the previous weightless state of our fetus is now pressing down on the umbilical cord, causing cord compression, as well as painless vaginal bleeding. And this is due to vessel rupture. So let's review some of our important differential formation points. We're going to have bleeding. It's going to be non-painful, and it's going to be continuous because our vessel has ruptured now, so it's just bleeding out. This is a placental vessel, so the mother has no sensory reception here, so it's not going to be painful. And we're going to see fetal distress because the umbilical cord is the fetus blood supply, and so it's not getting blood, and so it's going to show symptoms of distress, but the mother will not have distress. They're going to be losing a little bit of blood, but not as much blood as compared to the fetus, so largely this is going to be without maternal distress. So let's go ahead and review here in our dark green. We're going to have fetal vessels covering the cervical os. This is associated with our velamentous umbilical cord, and we're going to have our triad of membrane rupture, fetal bradycardia from cord compression, and painless vaginal bleeding. I'm going to go ahead now and clear drawings again, so take another screenshot if you would like for your personal notes. And now let's move on to talking about the placenta accreta spectrum. So placenta accreta is essentially going to be when we have abnormal invasion of the placenta into the uterine wall. So if we look here, this placenta is nicely positioned right alongside the uterine decidua, and that's exactly what we like in a normal placenta. However, what can happen in placenta accreta spectrum is we can get movement of this placenta or invasion into deeper structures of the uterus, and this exists on a spectrum because there are actually 3 different types. So our types are going to be accreta, increta, and percreta, and these are going to be based on the increasing depth into the structures of the uterus. So let's go over placenta accreta first, which is going to be attachment to the uterine myometrium. So here I'm going to have this little jagged line to show that our placenta is attaching to the myometrium. I'm going to put a little A here so you can see that this is accreta. As opposed to increta, when we have the placenta that's actually going to come in and invade the myometrium. So you can see here now that we're actually not just attached, but we're inserted into the myometrium here. So I'm going to put a little I here to demonstrate that this is increta. And then finally we have percreta, where we have penetration all the way through the muscularis layer, and we're going to move past the myometrial layer into the other structures. And risk factors here are going to be poor decidualization. So anything that leads to poor decidualization makes sense, right? If we have a really thin decidua, it's going to be much easier for our placenta to kind of push through through that decidua and into the other structures. So things like increased maternal age, multiple gestations, infertility procedures, uterine surgery, and C-section, right? These all make sense. These are all relatively traumatic to the uterine decidua. So let's just review the three different things really quick. We have accreta, which is attachment to the uterine myometrium, increta, which is penetration, and then we have percreta, which is penetration of the uterine serosa and pelvic organs. So go ahead and take a screenshot here. I'm going to clear screen and we're going to talk about placental abruption. So in placental abruption, essentially what is happening here is we have abnormal incorporation of blood vessels into the placental wall, and these blood vessels you can think of as being non-sufficient to support proper attachment of the placenta throughout pregnancy. And then what happens is we usually have some sort of blood vessel failure at some point in the pregnancy, and then we have plus or minus trauma. And I'm going to highlight this trauma in bright red because usually this trauma is going to be described as like a motor vehicle accident or some sort of physical trauma to the womb. And essentially what happens is this placenta here is going to detach from the wall from this trauma from the outside, and that is going to lead to our placental abruption. And so essentially what is happening here is this detachment is going to lead to a lot of bleeding from the maternal side, and this is going to be bleeding that can be felt. It's going to be painful because the mother has receptors in the uterus that can feel pain, and so this bleeding is going to come out here of the cervical os and will be seen as vaginal bleeding that is painful, and this is going to be accompanied by maternal and fetal distress. So let's review here. We have bleeding. This bleeding is painful because it's coming from the uterine wall where the mother can feel it, and it is going to be continuous bleeding, and it's going to lead to fetal distress because the placenta is no longer supplying blood to the fetus, and it's also going to lead to maternal distress because this is massive amounts of hemorrhage, and the pregnant person is going to start feeling things like hypovolemia, so tachycardia, shortness of breath, pallor, diaphoresis, things like that. So let's kind of talk about why this blood vessel formation can be poor. So essentially we have that blood vessel failure in the decidua basalis, and then plus or minus trauma, we can get the placenta detaching from our uterine wall. So risk factors are going to be everything that's related to vasoconstriction. So I like to think of things like smoking, cocaine, and hypertension, especially those of the preeclamptic type. And then especially uterine abnormalities are going to also contribute, because if we don't have a smooth uterine surface here, it's going to make it a lot harder for the placenta to hang on. So things like fibroids or a bicornuate uterus are going to be risk factors as well for placental abruption. And we talked about our presentation. It's going to be sudden pain. So as soon as that placenta detaches, usually in the setting of some sort of trauma, it's going to be ouch, big pain. And that's because the pregnant person has pain receptors in the uterine wall. And then we're going to have bleeding in the third trimester associated with contractions, and this is going to be continuous bleeding. We're also going to have some complications like DIC, and this is due to tissue factor activation from the ripping off of the placenta from the uterine wall. And then we're going to have the unstable vitals and fetal distress. So both mom and fetus are experiencing distress here, like we mentioned above. And then we can also see a retroplacental hematoma on ultrasound, and that's going to be a collection of blood back here in the area between the uterine wall and the placenta. I want to quickly mention a differential here for you guys. Let's start by talking about uterine rupture, which is not quizzed heavily on step 1, but I want you guys to be aware of it. This is also going to present with pain in the mother. However, we would expect to have an irregular uterus on physical exam. So if you were to palpate out here, you might palpate like a foot or an arm or a piece of baby that had slipped out of a uterine wall that had literally split open, and that's going to be an important differential, especially more towards step 2, but I wanted to mention it here. And then also we're going to have Sheehan syndrome on our differential, because all these conditions can lead to quite a bit of bleeding, and we know that our pituitary is a watershed area, and Sheehan syndrome is when our pituitary becomes starved of blood, and then we expect endocrinopathies post-delivery in the pregnant person. So in terms of our high yield review, I would say it's really important to focus on these 3 points in order to form your differential. It's going to be important to note if there's pain, it's important to note the type of bleeding, and it's important to note if there's maternal or fetal distress. And we talked about the fact that placenta previa is going to be when we have placenta placenta in front of the cervical os. Vasa previa is vessels in front of the cervical os. Placenta accreta spectrum is variable depth of invasion into the uterine wall at a pathological level. And finally, placental abruption is going to be when the placenta detaches from the uterine wall, and this is going to be due to poor vascularization or vasoconstriction. And we talked about some important risk factors there, like smoking, cocaine, and hypertension. And then finally, in terms of our differential, we talked about our uterine rupture, which is going to be accompanied by an abnormally shaped uterus where you can feel fetal parts slipping out of the uterine wall, as well as Sheehan syndrome, which is an endocrinopathy secondary to blood loss during delivery. I hope you guys enjoyed this video. Can't wait to see you guys in the next one. Bye!